All right, everyone, thank you so much for being here. We are a sparse group because it is 4 o'clock and we're all talked out. But our group would love to discuss with you strategies for increasing diversity and inclusion in emergency medicine and finding solutions to recruitment and retention through a synergistic modeling system. So I'm Taneisha Wilson. I am an assistant professor at Brown Emergency Medicine, very junior faculty. I am interested in diversity and obviously in our workforce and in our patient population and how we can optimize that care delivery. And our moderators today for our discussion are going to introduce themselves. So we'll start with Tracy on this end.
Hi, I'm Tracy Madsen. I'm also from Brown University, and I focus on sex and gender research as well as looking at bias through a gender lens. So excited to be here.
I'm Joel Moll from Virginia Commonwealth University, and I usually talk much better.
I agree. We have the same cold. I'm Alyson McGregor, and I'm also at Brown University, and I'm the director for the Division of Sex and Gender in Emergency Medicine.
I'm Christian Arbelaez. I will be getting a cold probably in about a week. I'm the Vice Chair of Academic Affairs at Brown. I've been doing diversity work pretty much all my life at the different levels, and not only at the hospital medical school, but at the state level.
I'm Tara Overbeeke. I'm an assistant professor at Vanderbilt University. I started WAM, which is a Women in Academic Emergency Medicine group at Vanderbilt for our female emergency medicine physicians and residents and faculty.
Sheryl Heron, Vice Chair for Administrative Affairs at Emory University School of Medicine, one of the assistant deans, have been engaged with ADIEM as the founding president, and very much interested in this work for about 20 years. Thank you.
So we have no disclosures, but this talk is sponsored by ADIEM, and we are all members of AWEM and the Sex and Gender Interest Group. So at the end of this discussion, we hope that you'll be able to describe the current state of gender and racial diversity in emergency medicine across all stages of EM. We'll talk about that in a little while. And we hope that you'll be able to describe the data on the proportion of physicians who identify as LGBTQI across the stages of EM. And we also hope that you'll be able to describe the link between the lack of diversity and in the physician workforce and the negative impact that this might have on patient care. And finally, we hope that we'll be able to identify 3 examples of best practices or solutions to increase gender and racial diversity in emergency medicine. So at the risk of preaching to the choir, I know we all care about this work, and I figured since this was another animal hitting a horse, it wasn't so negatory, but we've had multiple discussions this week about diversity in emergency medicine, right? And we all understand why it's important. Physician relationship with their patients are impacted by just the fact that your physician looks just like you. There's been multiple studies that show that physician concordant race increases patients' compliance. I know we all hate that word, but compliance with taking their medications, showing up for appointments, and ultimately their outcomes. Black patients who have a black doctor take their antihypertensives, take their anti-diabetic medicines more than physicians who have a discordant physician. And we can extrapolate this data to include women and patients who are transgender or other sexual and gender minorities. So looking at this map, we know that the US population is diverse. Approximately 32% of all patients who come to the emergency department are non-white, identify as non-white, and that includes Hispanic, Latino, African American, Native persons. 37% of the U.S. population is non-white, and as you can see in so this graph here, who can tell me what this map kind of represents? Which racial identity or population does this map represent compared to this one? Like, who are these folks? Latinos, exactly. So as you can see, that this is kind of the spread of our Latino population, and this is from the CDC U.S. Census data from 2016. And this kind of is our distribution of, or congregation of African American or Black population in the United States. And this will come up in a little while. So we know that our population is diverse. That diversity is somewhat concentrated in certain areas, but even in Utah, Colorado, Illinois, New York, you can see the population there is about 14 to 20% African American or Hispanic. So what we know about our emergency medicine specialty, for women in EM represent about 37% of trainees, but women are about 50 to 51% of the population, so that doesn't quite make sense. And from a race perspective, for both medical students and residents, URMs comprise about 9% of the total population, whereas in the hospital population, that's 32%. In the United States population, that's 37% of all URMs. And unfortunately, for LGBTQI data, we don't really have that data. There's some data suggests that LGBTQI trainees are about 2% of the trainee population, and in the general population, they represent about 3.8% of the population. So still, there's that discrepancy. And so I promised you that at the end of this, you would know what the proportion of LGBTQI trainees and physicians would be across all stages, and I lied to you. I'm sorry. So just looking at medical students specifically, this is AAMC data. That the darker color represents kind of a concentration of URMs. This is just focused on race. And as you can see, there's Texas and some of these states are doing okay, and they're about 200 to 300 URMs in their medical schools. Indiana is actually doing really well, which is very strange. But this map, sorry, you can always jump in. But this map, right, does not correlate even just closely to what we know the U.S. population represents, right? I don't expect URMs that live in Texas to be going to Montana or Utah or Wyoming, but you'd at least expect a little bit more of a concentration in California, say, or even New York. Florida's doing okay. Mississippi, surprisingly, looks almost just like Colorado. And I checked to see if they have a medical school, and they do. It's yes, the University of Mississippi. They have about 400 graduates per year, so I was very surprised by that data. So this is just for trainees, and we can see that there is a dearth of just the amount of students that we can even pick from to going to residency, and then to go from residency to go to academic medicine, and then to kind of get promoted, right? So we are starting at a very small number is the point. And so the AAMC does collect data on your professorship once you get into academic medicine. And so in early career, which we use here to mean clinician educators and assistant professors, anything below that rank, you can see that women, again, make up about 30% of this population, and at the assistant professor and below level, URMs make up 8.2% of that population. Again, I've showed you the comparison with the nation. And LGBTQI, we don't have that data as well. And for mid to late career, that's associate professor and above professor, endowed chairships, and et cetera. Women actually have kept their numbers and do represent about 31% of that group, which I was actually surprised by. I thought it'd be less, but this is data from 2017. So I looked at 2016 or 2014 because I was surprised by this data, and at that time it was about 28%, so not that big of a change. And again, I don't know what the higher ranking of LGBTQI physician is among the groups, because we just don't have that data. I'm going to just pause here real quick. Who knows what this is? Okay, go.
The graduating class was a point, I believe. They graduating the largest number of African American women in the history of the university. They have, 217 years worth of history.
Right, exactly. So this is the 30 women out of their 950 graduates at West Point, which, it doesn't sound like a lot, but last year they had 25. And in 2002, they had 13. In 1989, they had 9. And so how they've increased their graduation rate of black women specifically, not including all the identities, but black women specifically, is that they went into high schools and elementary schools and were very aggressive about their recruitment effort. And like I said, the number doesn't seem that much, but just the visual itself, right, is just so appealing, right? You're just like, as a young black woman in high school, you're like, well, wait a minute, I can go to West Point, right? And so I think that we can use some of their tactics to apply to our recruitment efforts, which is we have to be very aggressive, and we have to start even earlier than we think. So now, we'd like to break up into small groups to discuss some of the best practices for increasing trainees, increasing the gender, racial, and ethnic minority group among trainees within the early career group and the mid and late career group. And now, I don't quite have the solutions for you, right? But we have some ideas of what works. ADIM has proposed some of those ideas, so we kind of know what works. What we want to hear from you is what has worked at your institution, and we'll kind of collate this data and discuss it at the very end. So we'll take about 15 minutes to talk amongst ourselves. And as you can see, we actually have maybe enough folks to break up into groups. So if you could just count off by 3, and Mary and Kelly Wong are going to be taking notes, myself are going to be taking notes, so we can kind of come together at the end and put together our best practices here. So if you could just count off by 3. So Libby, you'll start. 1, Marquita, 2, Bernie, 3. All right, team. So we'll break now and have our facility. Wow, this is getting heated, talking about salary and equity. So we'll have our moderators, we'll start discussing with the trainees what our moderators found that were some of the best practices and solutions that our participants discussed from a gender, race, and LGBTQI perspective. If there's anything that stood out to your team. So Joel and Alyson. I don't have a mic, but we can put this down. Just stretch. Yeah, you can.
'Cause we don't want to yell. Us too. Yeah. So one of the things that our group discussed was the fact that if you have a medical student or a resident or a fellow, you want to continue to recruit underrepresented URMs. But how do you do that when they look up at the next level, they don't see any? And so how do you begin the recruitment process? And so we came up with a lot of ideas, actually. One is to showcase that even though you don't have URMs visible that you can see, your value system is there. And so having the leader of your department make sure that when they are recruiting, or the residency director, that they stated out front that diversity and inclusion is very important to them. One suggestion was to have the times that interviews are happening, maybe have the grand round speaker be an underrepresented minority, or at least talk about the values of that. And I'll say one more, and then I'll let you say some. One of the things we were saying also is when you don't have how to begin that process. Utilize it. Look outside of your own specialty. So maybe one of the things that one of our group members here finds that successful is having an LGBT group that meets monthly for all medicine. So not just emergency medicine, it's internal medicine and surgery. And so that way you can find your basis. And within medical school, like maybe the medical school has something. Maybe when we're looking for residents and we're discussing with them opportunities, we can say, well, the medical student has this interest group that meets, and you're welcome to join that too. So we really sort of, one of the first things we want to do is how to begin the process when you're not established already.
since I don't have a voice, I'm not going to add much to that except to say that I think some of the things that people talked about is, again, kind of creating that environment and values and culture. So, for example, if you don't have work you're doing on, women's health or what have you, or LGBT or underrepresented minorities, but maybe you're doing something on refugees, to your point, putting that out there makes people understand that, you sense if it's a diverse and inclusive environment, as opposed to, it may not be the perfect environment, but you sense that it's out there. And so publicizing some of those things, I mean, I, as a gay man, am more likely to go to a program that values underrepresented minorities, based on their race and ethnicity and gender, because I know they're probably likely to be more accepting of myself as well. So I think it's important to think about all aspects of the diversity profile.
Okay. Thank you. We'll kind of synthesize that in 1 second. But Tracy and Tara, what you guys discussed in your early career group?
Departments have designed or organized female faculty groups, and which allows for peer mentorship, even if you don't necessarily have a lot of senior female faculty, but in a group kind of mentorship. And then also talking about family leave policies and letting applicants know about what the departmental family leave policies are, that it's parental leave for males and females, and also having kind of gender-specific, having male allies kind of involved in female faculty groups as well, like chairs of the departments. And then I don't know if you want to talk. Sure.
So we also talked a little bit about race in our group in early career and retention and recruitment. And some of the ideas we talked about, one was ensuring adequate mentorship and sponsorship for URM individuals in their early career. And one of the ideas we discussed was making sure that URM individuals aren't given all the diversity and inclusion work in their department, and that they're not expected to do all service and not be given time for their own careers. And so if they are doing a lot of service, and helping them to use the work that they're doing, that the work that they're interested in towards promotion, towards scholarly activity, or whatever it is that's needed for promotion. We also talked about working across departments to help create a sense of community for URM individuals. And then finally, we talked about, in terms of retention of early career faculty, really ensuring an environment where there's salary equity and equity in promotion and advancement to make people feel like they're being treated fairly and they're in a safe place.
All right, thank you. So I'm not sure the mic's going to stretch all the way over to Sheryl and Christian. And that one, it's taped down. So I don't know if you guys want to come up to the podium or talk. Okay, we can hear you, I think.
Well, if you can imagine 20 years of that pipeline that you guys basically have just walked through, I think we started out by talking about attrition and the loss of a lot of the efforts that go on at the pipeline, at the start of the pipeline, and the K-12 grade, that it takes about 20 years for somebody that sort of decides to do emergency medicine
So that was a great summary. I feel like I shouldn't even say anything else, but I do want to kind of point us to what we're all talking about, right? We're talking about, first, we have to have enhanced recruitment, which we all acknowledge is first the first need. So for us, we're pulling from a school, a bunch of medical schools, the same sort of URM candidates, the same women who are amazing, the same LGBTQI candidates. So we need to get students in from the very beginning so we have a bigger pool to choose from, especially in their own local communities. And then we talked about community and culture. So creating a safe space for folks, ensuring that you do have parental leave policies, ensuring that you do have a community that's supportive. And someone in our group had mentioned the fact that, yes, women are underrepresented in EM, but that's still a bigger cohort. That's still 30% versus the 8% of URMs that's there. And if you think about LGBTQI as well, that percentage is even less. And if you think about that, people who identify as one of all those things, that's even less. And so finding that community, not just within EM, but outside of EM, sounds like it's important. It might be a good solution for us all to bring back to our institutions, right? Also, we talked about some, we didn't quite use the word organizational accountability, but we talked about how the fact we have to have some chair buy-in, right? We have to have your institutional buy-in to kind of increase all your efforts or improve your efforts in all areas. And regarding promotion and advancement, there is the black tax. I mean, I've heard this term since I was, I think, in high school, right? I think it's the same for women and LGBTQI. Like, you are the one that's pulled to do all the things for the folks that kind of look like you and feel like you. And we, for the most part, enjoy that work. But how do we operationalize that work to include in our portfolio in a meaningful way for advancement? And I think as we continue along the continuum, we need to sort of emphasize that and help our junior faculty and residents and fellows kind of navigate that experience. So I think that mentorship, community, and finding a good well to tap so that we can keep the pipeline going. And the pipeline is not straight, right? It's a giant loop. So we start at elementary, high school, middle school, college. We go to medical school. As Christian mentioned, that's decades, right? We go to residency, and then we get promoted in an academic institution, and then we have Dr. Heron, who, brings it back to the community, right? So I feel like this pipeline that we're describing, this circular pipe, is very important. The strategies that you guys highlighted, I think, are very important. We should sort of all bring this back to our institutions. So look forward to our white paper about what we discussed today. If you have any other ideas or thoughts, please don't hesitate to email me or Tracy, Tara, Alyson, Joel, Christian, or Sheryl about your ideas, because I think we are all at each of your institutions, it looks like. Questions, thoughts, concerns?
One suggestion, do you want to capture the folks who are here with my name and on this assignment sheet that's voluntary?
Oh, yeah, absolutely. If you would like to, we have our list from our group, but Mary and Kelly, do you mind just taking out everyone's name from your group as well? Just make sure I got it. I think I have everyone. Any other suggestions? But thank you so much for that robust discussion. Like I said, it's all the things that we've all talked about before, just from a different lens, talking about it from the training continuum as opposed to specifically from a, just a sex and gender or a URM focus, because they all do intersect. It's true. Thank you all so much for your time.